So our first speaker here is Dr. Hediyeh, Barada, MRA techniques and their role in stroke imaging from the University of Utah.
Hello, good morning. Perfect pronunciation. Hi, I'm Hediyeh Barada, and I'm one of the neuroradiologists at the University of Utah. It's my pleasure to be here. It's my first time at the MRA Club, and I've heard a lot about it even in training. I trained with Dr. Prince, and I'm at the University of Utah with lots of great vascular MR people. So I don't have any disclosures besides what I just said, and today we're going to be talking about MRA techniques in the setting of acute stroke. A little bit more of a clinically focused talk, but we'll talk about some MRA imaging techniques as well. Just as an overview, so we're going to talk a little bit, just to touch on the utilization of acute stroke. We heard a lot about that this morning. And then we're going to talk a little bit about why to use MRA head and neck in the setting of acute ischemic stroke. Just a quick overview of techniques and how MRI can be helpful in both acute stroke and evaluating stroke etiology. So just as a background for people who are not neuroradiologists or in that field, so acute ischemic stroke is a very large cause of morbidity and mortality. The incidence is about 200 per 100,000 per year, and neuroimaging is actually a huge proportion of the costs associated with stroke hospitalizations. So it's a very important part of stroke care. And a lot of this has really been accentuated by the fact that about 7 years ago, the American Heart Association endorsed endovascular therapy, specifically like mechanical thrombectomies in the setting of acute stroke. So this has really made neuroimaging in particular the corner piece for stroke care. It is how we triage patients, and it's a very critical portion of stroke care. So we talked a little bit about this, but just to touch on this again, so this is a figure showing trends in neuroimaging utilization from 2012 to 2019 based on the Medicare sample, and you can see that MR has increased steadily over the last, throughout the time period, about an 18% increase. However, MRA has kind of decreased steadily. You can see a little bit of an inflection point around 2015 when the AHA made those recommendations. It's kind of interesting that though the decoupling of the MRI, which has been steadily increasing, but the MRA has been decreasing. Conversely, we see a very rapid increase in the use of CTA and CTP. CTA has increased about 250%. CTP has increased about 400%, although from a very low level. So I think to understand why MRA is not being used, I think we need to realize, kind of take a look at why CTA is so appealing in the setting of acute stroke, and that is it is very accurate and rapid means of detecting a large vessel occlusion, which is one of the most important things to determine in the setting of an acute stroke. So it can be performed very quickly, it's widely available, it has very few contraindications, renal disease probably being the most notable, and it really is an accurate assessor of large vessel occlusion and stenosis. And so that is why it is really kind of taken off in the setting of acute stroke to help manage patients and determine who is eligible for thrombectomy. But today we're going to talk about why we should use MRA and how it can be useful. And I think this was touched on earlier, but I really think the biggest reason and the biggest argument to make for MRA in the setting of an acute stroke is that it can be performed at the same time as a brain MR. So CT and even CTP is far inferior to MR in determining the degree of core infarction. There really is no contest between the two. Diffusion-weighted imaging is really the gold standard for determining core infarction, and without it, we're making guesses based on the CT, but it's not going to be as accurate as MR. And so by adding on an assessment of the vasculature at the same time as getting a brain MR, we can really kind of do two things at once, get a very accurate assessment of the degree of stroke burden or infarcted burden, and then also look for large vessel occlusion or stenosis or any other potential contributors to the acute ischemic stroke. So what other reasons are we using vessel imaging? So the point of vessel imaging in stroke is to really evaluate for large vessel occlusion, at least acutely, and MRA is good at that. And so some may argue that CTA might be a little bit better, but MRA is very good, and in fact it was used in nearly all of the thrombectomy trials interchangeably with CTA. And so lastly, I think another place that MRA can really shine is in stroke etiology determination, and we're going to talk a little bit more about that today. So first, just quickly talk about the techniques in acute stroke. So I think most institutions in the setting of an acute stroke, time is of the essence, as we mentioned, and so most people are using a simple 3D time of flight non-contrast MRA of the head to evaluate for stenosis and to look for any sites of luminal narrowing. This is, relatively quick exam, less than 5 minutes, and can be tacked on to a rapid MR in order to exclude any kind of occlusion. So here are just a couple examples. So we have a patient, this image here, hold on, I don't know. Sorry, this image on the top left is a diffusion weighted image where you can see there's acute infarction in the left MCA territory. And then we can see that there is an abrupt occlusion, abrupt cutoff in the M1 segment of the left MCA. And these are just MIPS images of the MRA. So another case, here this patient had a small infarction in the left insula, and then we can see that there's a cutoff in the M2 segment of the MRA. So MRA really is quite good at detecting large vessel occlusions in the setting of stroke. So another thing that we want to use MRA for is looking for any areas of stenosis, and so a luminal caliber assessment. So there are lots of reasons for vessels to be narrowed intracranially, but the most common is intracranial atherosclerotic disease, and it's a major cause of ischemic stroke, and it has a quite relevant contributor to intracranial ischemic stroke. So here's just an example. So the last example I showed was of in the MCA. You can see that there's some narrowing in the MCA in that vessel. But here, this is an example of an ICA. And so we can actually use MRA images to get a rough estimate of stenosis using the warfarin aspirin symptomatic intracranial disease technique. So it's similar to the NASIC technique that we use in the extracranial vasculature, where we measure the site of greatest luminal narrowing compared to a site more proximally with more normal appearance of the lumen. So while we can use MRA to fairly accurately assess intracranial stenosis, something that's very important that we're going to be talking about a lot throughout our time here is some of the limitations of head MRA, and that is, especially in the intracranial arteries, luminal stenosis does not equal stroke risk. So in this example, this is a patient who had a left MCA stroke, and they'd had a CTA and an MRA before that were, basically normal. The radiologist didn't detect any significant narrowing, and they went on to get a vessel wall MRI, which is what these images are showing here. And you can see that there's an eccentric T2 hyperintense plaque kind of in the inferior aspect of the MCA that is showing enhancement. So this was the culprit plaque thought to be the reason that the patient was having a stroke. So this happens for a number of reasons, which others will be talking about in greater detail, but just to give a brief summary. So intracranial arteries often experience this something called wall remodeling. So there's this outward bulging of the lumen wall in the setting of plaque, thought to be an adaptive response to preserve flow. And so because of this, the angiographic imaging like CTA or MRA can look completely normal. It can look like there's no significant narrowing. And it really takes evaluating the vessel wall itself to assess for enhancement and to actually visualize the plaque in order to detect these sometimes subtle plaques, but important plaques nonetheless because they are contributing to ischemic stroke. So even just having positive remodeling is associated with ischemic stroke. So even just the presence of remodeling itself is a positive predictor for stroke. And so I think MRA is essential in the setting of acute stroke, or at least angiographic imaging is essential. And I think using it as a complementary tool with vessel wall MRI can really provide the most accurate stroke risk assessment. And so in this example, these are just another patient who has this enhancing plaque in the right MCA. And plaque enhancement is another marker that's strongly associated with symptomatic or culprit plaques with odds ratios ranging from 7 to 11, so a very strong predictor of symptomaticity in the setting of acute stroke. Okay, so we're going to be moving on to MRA of the neck. And so MRA of the neck, the protocols are a little bit more varied. So some people use contrast in the setting of acute stroke even. Many people do not use contrast in the setting of acute stroke. There are a couple sequences that I think that most people use throughout institutions. So a 2D time of flight MRA, kind of extending from the aortic arch to almost the circle of Willis, is an important component to evaluate for flow assessment. Most use a 3D time of flight centered at the carotid bifurcation. And then I would argue that an MP RAGE or a similar sequence is really critical for all patients that are being worked up for acute stroke. And then again, contrast-enhanced MRA is also a beautiful tool for evaluating other parts of the vessel, including interluminal thrombus or plaque ulceration, things that are a little bit better assessed in the setting of contrast. So we're going to go through a couple of the imaging findings that are important to look out for when evaluating acute stroke patients on a neck MRA. So first, something you can see not super commonly, but it's important to note on a MRA is intraluminal thrombus. So this is when you have kind of a free-floating thrombus adherent usually to some kind of plaque. And you can see on these contrast-enhanced images, there's a central filling defect on the axial, and you can kind of see it free-floating on the sagittal views. And so this is a contrast-enhanced MRA, and that really is the most accurate for detecting intraluminal thrombus, although it can also be seen on time-of-flight MRA. So that's, sorry, I should have said that's strongly associated with acute ischemic stroke. So next, of course, on every image that we look at for any kind of MRA or CTA of the extracranial vasculature, it's really essential to evaluate for the degree of NASIT stenosis. And you can see it's kind of a rough estimate of how NASIT is measured, and contrast-enhanced MRA is pretty much equivalent to CTA when evaluating for NASIT stenosis. So as we know, evaluating for NASIT stenosis is a critical part of our workup for stroke, but as we've kind of learned more about plaque physiology and plaque biology, we have kind of entered this paradigm shift in how we view stroke risk. And rather just thinking that there's kind of this flow limitation in the setting of carotid stenosis that's leading to a downstream infarction, we've become more aware of the actual plaque itself and its ability to throw thrombi, leading to a thromboembolic stroke. Likely there's some synergistic effect between the two processes, that some kind of flow limitation kind of hastens the development of a stroke in the setting of a thrombus being sent off from a vulnerable plaque. But because of our understanding, we've really focused our attention on the plaque itself and not just the degree of narrowing. And so while measuring the degree of NASIT stenosis is a critical part of the MRA neck, if we could add on a quick sequence to look at the plaque itself, it would be very helpful in our assessment of stroke etiology. And so MP RAGE is really the sequence that is best suited for this, although you can see it on time of flight. And the strongest marker, a really key parameter for stroke risk in vascular imaging is intraplaque hemorrhage, or even just a high intensity signal that we see. And we've talked about this, many years here at this conference and throughout, but it's really very strongly associated with future and recurrent stroke. There is very robust histopathologic and imaging and clinical evidence supporting intraplaque hemorrhage as a very strong risk marker for future and ischemic stroke. And really, we can see it without specialized carotid coils. We can see it using a very straightforward MP RAGE type sequence, which can be done in a matter of minutes and added on to most MRA necks. And here are two examples of an MP RAGE image where we see this crescentic T1 hyperintensity narrowing the lumen in two different carotid arteries here. You can see that the intensity is about 2 times greater, more than 2 times greater, the adjacent sternocleidomastoid muscle, which is what is traditionally used as a marker for intraplaque hemorrhage. So the beauty of intraplaque hemorrhage, or this high intensity signal, is it can be seen on a lot of different images. So even a standard 3T time of flight. So if you don't want to spend the extra time to do an MP RAGE because the neurologists really want to get the patient to thrombectomy or get them to the floor to admit them, you can still see it on a 3D time of flight. And this image on the left, you can see that high intensity signal narrowing the lumen, which is compatible with intraplaque hemorrhage and has been established associated with increased risk of symptomaticity and stroke. And there's just a couple more examples of another patient with a coronal MP RAGE where you can see the intrinsic T1 hyperintensity, and then again on a MIP of a 3D time of flight. So another marker of stroke risk for plaque is plaque thickness. The maximum plaque thickness is actually more strongly associated with ischemic stroke than even the degree of stenosis. And so it's an important marker for stroke risk, and again, can be easily measured either on a time of flight or an MP-RAGE image when evaluating an MRA neck. And MR is much better at assessing this than ultrasound and other techniques too. And then, of course, there's ulceration. So contrast-enhanced MRA is certainly kind of the most well-established and best way to evaluate for ulceration. You can see that's the image on the right there. You can see the extension. So the technical definition of ulceration is extension of the luminal contrast into the plaque by at least 1 or 2 millimeters, which we're seeing in that plaque there. But actually, you can see it on time of flight. So even on non-contrast imaging, the other image we have is just a standard time of flight where you can see the extension of the lumen into the plaque compatible with the plaque ulceration. There's a lot of data supporting a ruptured fibrous cap around the plaque that we usually see in the setting of really dedicated carotid plaque imaging. And while this is not that dedicated carotid plaque imaging, these are images were taken with a standard coil. But so we know that there's strong evidence that having a rupture in your fibrous cap is associated with ischemic stroke, and that's strong prospective evidence. But we don't have that same strong prospective evidence for just kind of this general plaque ulceration. But it would make sense that this plaque ulcerations are associated with future stroke, and they have been strongly associated cross-sectionally with symptomatic plaque and stroke in that sense. So just going to review quickly the imaging that we talked about today. So MRA head, so most people are doing 3D time of flights, and that really just to assess for an acute occlusion and any kind of luminal narrowing. I think in the setting of cryptogenic stroke or embolic stroke of undetermined source, having a low threshold for vessel wall imaging is really critical here because of the limitations in our ability to evaluate for any kind of non-stenotic process that could be contributing to stroke. MRA neck, there's a few sequences that people can choose from, and we kind of talked about that earlier in the session too, about how it's difficult to decide which sequences to do. But a 2D and a 3D time of flight are really important, as well as, I would argue, an MP-RAGE. Contrast-enhanced MRA is nice to have, obviously, if you can, but it's not critical in the setting of acute stroke, but can be helpful for further evaluation. I thank you so much for your time, and I look forward to answering any questions in the following session.